You know, when you think about riding out a massive storm, almost all of our attention goes to the really turbulent part,
Oh, absolutely. The chaos.
right? The chaos. You batten down the hatches, you weather the high winds, the sheer unpredictability of it all. And then, when the sky's finally clear, everyone just sort of breathes this huge sigh of relief. You maybe clean up a few branches and celebrate.
But what happens next?
Exactly. We rarely talk about what it actually takes to live in the entirely new landscape that the storm leaves behind.
Yeah, the focus is almost exclusively on surviving that transition. I mean, we treat the end of the turbulence as the end of the story. But biologically speaking, when we look at the female body, that post-storm landscape is, well, it's the beginning of an entirely new era.
And that's exactly what our mission is for today's deep dive.
Yeah.
We're figuring out what life actually looks like after that storm.
Yeah.
I mean, what exactly is postmenopause? And crucially, how long does it last? And to do that, we've been toming through just a massive stack of medical literature today. We're talking guidelines from the National Institute for Health and Care Excellence, or nice consensus statements from the British Menopause Society, the American Urological Association, and just dozens of clinical research papers.
It's a lot of data.
It is a lot of data, because the reality is society talks endlessly about the turbulent transition of menopause. But this phase we are looking at today, post-menopause, is just profoundly misunderstood. It isn't just an ending.
No, not at all. It is a distinct, prolonged biological state. I mean, it requires a completely different understanding of how a woman's body functions. And it really starts with just getting the terminology straight.
Right.
Because the way we casually use the word menopause in everyday conversation, it's completely different from how it's defined in the medical literature.
Okay, let's unpack this. Because when people say menopause, they usually mean, the hot flashes, the mood swings, the irregular periods. But the sources, like the British Menopause Society, are very strict about this. They note that the average age of menopause in the US and the UK is 51.
With the normal range between like 45 and 55.
Right. But medically speaking, menopause isn't actually a phase of life at all.
Clinically, menopause is just a single point in time.
Wait, really? A single point?
Yeah, exactly. It is diagnosed exactly 12 months after a woman's final menstrual period. So it's an entirely retrospective diagnosis.
Oh, wow.
Right, so during those 12 months of waiting, she is still technically in perimenopause. But the very day she crosses that 12-month mark, she officially enters postmenopause.
So if menopause is just a single day on the calendar, that completely shifts how we think about this. It actually reminds me of graduating from school.
Oh, yeah. How do you mean?
Well, you spend a few really chaotic, stressful years in the transition, right? Taking exams, figuring out your life, pulling all-nighters. That's perimenopause. Then you cross the stage at graduation, they hand you the diploma, and that single day, that's menopause.
I love that.
But after that day,
Yeah.
you are an alumni for the rest of your life. Like postmenopause is the alumni status. It's not a temporary phase to get through. It's a permanent new normal.
That's a perfect way to look at it. And if we connect this to the bigger picture, the implications of that permanence are massive. I mean, think about the historical context. A century or two ago, human life expectancy was significantly shorter.
Right. Women might have only lived a few years past that final menstrual period.
Exactly. But today, because human life expectancy has increased so dramatically, a woman might spend a third or even a half of her entire life in postmenopause.
Wow. So you're looking at 30, 40, maybe even 50 years in this biological state.
Right. Which is why we just can't afford to ignore it or treat it as an afterthought. Understanding how the body operates during a 4-decade stretch is absolutely vital for long-term health.
Okay, so if we're living in this state for 40 years, what is actually happening under the hood during this lifelong phase? Because the ovaries aren't just taking a vacation. They are like permanently closed for business.
They are, and it all comes down to a really profound shift in the hormonal landscape, specifically estrogen. And to really grasp this, we have to look at the numbers.
Let's hear them.
So during a woman's reproductive years, her primary estrogen, which is a highly potent type called estradiol, fluctuates wildly depending on where she is in her menstrual cycle. It generally bounces anywhere between 15 and 350 picograms per milliliter.
Okay, 15 to 350.
But in postmenopause, the ovaries retire, they stop producing eggs, and as a result, that estradiol production just plummets. I mean, it flatlines below 10 to 20 picograms per milliliter.
Wow. And the brain does not like that sudden drop, right? Because from what I read in these endocrinology papers, The brain and the ovaries are in this constant communication.
Oh, absolutely. They are locked in a continuous feedback loop. So the pituitary gland in the brain is always monitoring estrogen levels. When estrogen drops, the pituitary senses the shortage.
Mm-hmm.
And to compensate, it starts producing massive amounts of a hormone called follicle-stimulating hormone, or FSH. The brain is basically shouting at the ovaries to wake up, mature a follicle, and produce estrogen.
So what are the numbers there?
Well, during reproductive years, FSH is pretty low, but in postmenopause, FSH spikes. It goes from maybe 5 or 10 international units per liter, rocketing up to 30, 70, sometimes even 90.
Here's where it gets really interesting. It's like a
Okay.
broken thermostat. Like the brain keeps cranking up the heat, cranking up that FSH to warm up the house, but the furnace, the ovaries, is just completely shut off.
Yes, the pituitary is effectively screaming into the void. The ovaries simply lack the viable follicles needed to respond.
But that raises a massive question. If you were listening to this and realizing your ovaries are effectively retired for the next 40 years, does the body just run on zero estrogen? I mean, what is keeping the lights on?
Well, the body doesn't run on absolute zero. When the ovaries step down, other tissues in the body actually step up to provide a baseline level of estrogen. It's this complex process called peripheral conversion.
Okay, peripheral conversion.
Right. So your adrenal glands, which sit just above your kidneys, continue to produce androgens. Now, androgens are typically thought of as male hormones like testosterone and androstenedione, but women produce them too.
And those androgens get converted?
Yes, mostly in fat tissue or adipose tissue. Fat cells contain an enzyme called aromatase, and this enzyme takes those circulating androgens and chemically converts them into estrogen.
Wow.
Yeah, mostly a weaker form called estrone, but also a small amount of estradiol. So fat tissue actually becomes the primary source of estrogen after menopause. The liver and even some skin cells participate in this conversion too.
So the body basically has a built-in backup generator. Like the main power grid went down, but the backup generator kicks on.
It does, but we have to remember it's a very weak backup generator compared to the ovaries. And this brings up a really fascinating and honestly highly critical medical caveat from the literature.
Oh, what's that?
Because this peripheral conversion is happening outside the ovaries, doctors have to watch it carefully. If a postmenopausal woman who is not taking hormone therapy gets her blood tested and her estradiol is high, say above 20 or 30 picograms per milliliter, that is actually a clinical red flag.
Wait, having more estrogen in postmenopause is a bad thing? I mean, you'd think the body would be thrilled to have the extra power.
You'd think, but it actually warrants immediate investigation. Because the ovaries aren't making it, high estrogen means the backup system, that peripheral conversion, is in overdrive, and we have to find out why.
So what causes that overdrive?
It could simply be linked to obesity because more fat tissue means more aromatase, which means more conversion. It could also indicate liver disease, where the body isn't clearing out old estrogen properly. Or, in rare but really important cases, it could point to an estrogen-secreting tumor on the ovary or the adrenal gland.
So high estrogen in a natural postmenopausal state isn't a bonus at all. It's a sign that the backup system is malfunctioning.
Precisely. The baseline is supposed to be low and stable.
Okay, so if the baseline is permanently reset to this low, stable hum, what does that actually mean for the famous menopausal symptoms? You hear so many people say, like, oh, I just can't wait to be through menopause so the hot flashes will stop. If the hormonal baseline is flat, do the symptoms just magically shut off at that 12-month mark?
I wish I could say yes, but the data reveals a very hard truth. They do not magically stop. Yeah. While the erratic periods and the severe cramping and the PMS are gone forever, other symptoms persist long into the postmenopausal era.
So let's talk timelines.
Yeah.
How long is this discomfort lasting?
Let's look at vasomotor symptoms, which is the clinical term for hot flashes and night sweats. The median duration for these symptoms is over 7 years. They typically last 7 to 9 years.
Wait, 7 to 9 years after the transition starts?
Yes. And for about 20% of women, these vasomotor symptoms can last up to 15 years into postmenopause.
15 years of hot flashes. That completely shatters the cultural myth that this is just a quick 2-year phase you grit your teeth through.
It really does. But there is another symptom profile that is even more persistent, much more progressive, and unfortunately way less talked about. It's called genitourinary syndrome of menopause, or GSM.
Okay, GSM.
Right. And up to 84% of postmenopausal women experience GSM.
84% is a staggering majority. What exactly is happening with GSM?
It's an umbrella term that covers a wide range of physical changes caused by the chronic lack of estrogen in the pelvic region. So we're talking about severe vaginal dryness, burning, thinning of the vaginal walls, pain during sex. But it also includes urinary symptoms like frequent urination, urinary urgency, and recurrent urinary tract infections.
So why do hot flashes eventually fade away for most women, but these GSM symptoms stick around and actually get worse? I mean, is it like a car alarm versus a leaky roof?
Oh, walk me through that.
Well, the hot flashes feel like a car alarm going off right outside your window. It's incredibly annoying. It wakes you up. It disrupts your life. But eventually, after a few years, your brain just gets used to the sound and you can tune it out. You adapt to the noise.
Right, right.
But GSM feels like a slow leak in your roof. You can't just tune out water rotting the wood. Without fixing the roof, the damage doesn't stabilize. It just slowly accumulates, and the ceiling eventually caves in.
That is a brilliant analogy, because the structural integrity is actually failing without the estrogen maintaining it. Hot flashes are essentially a neurological reaction to the withdrawal of estrogen.
It's just the brain getting confused.
Exactly. The brain's temperature regulation center, the hypothalamus, gets confused by the sudden drop. But eventually, the brain adapts to the new low estrogen environment. It recalibrates. The car alarm is still technically going off, but the brain turns down the volume. GSM, on the other hand, is physical atrophy.
The tissue is physically changing.
Radically changing. The urogenital tract is packed with estrogen receptors. When estrogen disappears, the tissues physically thin out, they lose elasticity, and blood flow decreases.
Oh, wow.
And even more crucially, the natural acidic ecosystem of the vagina changes. The protective bacteria that thrive on estrogen and keep infections away, they begin and die off.
Which leads to the infections.
Right. The pH rises, and harmful bacteria move in, which is why postmenopausal women are so prone to chronic UTIs. So unlike a hot flash, GSM worsens progressively over time because the physical structure is continuously degrading.
Okay, so if you're listening and thinking, well, I can manage a leak in the roof with some localized treatments, we have to talk about the rest of the house. Because reading through these cardiovascular and bone health sources, it seems the most dangerous parts of postmenopause are entirely invisible. So what does this all mean for a woman's long-term survival?
This is where we have to fundamentally reframe how we view estrogen. Culturally, we think of it just as reproductive hormone, the chemical that makes babies and periods happen.
Right.
But medically, estrogen is a structural guardian for the entire female body. Take the cardiovascular system. Estrogen protects the inner layers of the artery walls. It helps them stay flexible. It regulates blood flow and keeps inflammation down.
It also manages cholesterol, right?
Yeah.
I read that it helps keep the good HDL cholesterol high and the bad LDL cholesterol low.
It does, and it performs a very similar guarding function in the skeleton. Bone is a living, active tissue. We have cells that break down old bone and cells that build new bone. And estrogen keeps those two forces in perfect balance.
So it's like firing the maintenance crew of a massive skyscraper.
Yes.
Like the day you fire them, the building still looks perfectly fine from the outside. The windows are shiny, the lobby is clean. But deep inside the walls, without the crew actively working, the pipes, which are the arteries, start to rust and stiffen.
Exactly.
And the foundation, the bones, silently begins to weaken. You don't know anything is wrong until a pipe bursts or a wall collapses.
The risks spike dramatically once that guardian retires. Cardiovascular disease risk increases significantly, but the most immediate silent threat is to the bones.
How fast does that happen?
Bone density drops rapidly in the first few years of postmenopause because those cells start breaking down bone much faster than it can be rebuilt. Half of all women over the age of 50 will experience a fragility fracture in their lifetime.
Wait, half? 50% of women will break a bone just from a minor bump or fall.
Yes. Compare that to just 20.7% of men. Women are disproportionately affected by osteoporosis because of this sudden loss of their structural guardian.
That is wild.
And the real tragedy here is what the clinical papers call the treatment gap. In the UK, for instance, 66% of women who are at a high risk for a fracture do not receive any therapy for osteoporosis. They are left completely unprotected until the bone actually snaps.
Which brings up a really philosophical question. If the body naturally drops estrogen, why does it feel like a design flaw? Why is the female body left so structurally vulnerable for half of its life?
What's fascinating here is that to understand that, we have to look through the lens of evolutionary biology. Evolution is primarily concerned with getting a species to reproductive age, ensuring the survival of offspring, and maybe sticking around just long enough to help raise the grandchildren.
Right, the grandmother hypothesis.
Exactly. But for most of human history, life expectancy simply wasn't that long. The human body didn't evolve with a master plan for living 3 or 4 decades past reproductive age.
So we've basically outlived our own biological warranty.
We have engineered a modern world where we routinely live to be 80, 90, 100 years old, but our ovaries are still operating on an ancient biological clock that shuts down at 50, which is exactly why modern medicine has to step in to bridge that gap. We can't rely on evolution to protect postmenopausal bodies because evolution never expected them to be here this long.
So knowing that postmenopause lasts for decades and brings progressive risks to the heart, the bones, and the urogenital tract, how is this actually managed? We aren't just telling people to sit back and watch their foundation crumble.
Far from it. The guidelines from the British Menopause Society and NICE are incredibly clear on proactive management. Hormone replacement therapy, or HRT, is the first-line treatment for managing these vasomotor symptoms and protecting long-term structural health.
Okay, HRT.
And there is a massive misconception that we need to clear up based on the latest data. There are no arbitrary age limits on how long a woman can take HRT.
Really? Because you hear so much conflicting advice about women being forced to stop HRT after 5 years or the minute they turn 60.
I know, but the guidelines explicitly state that age or duration alone are not reasons to stop. If the benefits outweigh the risks for an individual woman, she can take HRT indefinitely. The method of delivery matters immensely, though.
How so?
Transdermal estrogen, which means patches, gels, or sprays that are absorbed directly through the skin, is preferred over oral pills.
Why is a patch better than a pill?
It comes down to the liver. When you swallow an estrogen pill, it has to be processed by the liver first. This process triggers the liver to produce clotting factors, which slightly increases the risk of blood clots and stroke.
Oh, I see.
But transdermal estrogen bypasses the liver entirely. It goes straight into the bloodstream, meaning it does not increase the risk of blood clots like oral estrogen can.
That's a huge distinction for anyone weighing the risks. And what about the GSM, the structural leak in the roof we talked about? Does systemic HRT fix that?
Systemic HRT helps, but for severe GSM, local vaginal estrogen is really the gold standard. This is a very low-dose cream, tablet, or ring inserted directly into the vagina.
And it doesn't affect the rest of the body.
Barely at all. Because the dose is so small and stays localized to the pelvic tissue, it barely absorbs into the rest of the body. But locally, it physically restores the tissue, improves elasticity, lowers the pH back to normal, and brings back the good bacteria to prevent those painful UTIs.
Wait, so just to clarify for the listener, a woman could be 75 years old and still using vaginal estrogen.
Yes, absolutely. Treatment should always be individualized and reviewed by a doctor annually, but age alone is not a reason to stop. An 80-year-old can and often should use local estrogen to maintain her tissue health and prevent infections.
That's incredible.
Also, the newest evidence shows that even testosterone, which women naturally produce and also lose as they age, is now being shown to help postmenopausal women maintain bone mineral density and sexual function. It's really becoming a full-spectrum approach to hormone restoration.
Okay, so we have systemic HRT, transdermal patches, localized vaginal estrogen, even testosterone. We have a massive toolkit. But as we comb through these clinical guidelines, there is one warning that appears in bold print across almost every single urology and gynecology source. The ultimate red flag.
Yes, postmenopausal bleeding. If a woman has gone 12 full months without a period, meaning she is officially in postmenopause, and she experiences any vaginal bleeding, she must see a doctor immediately.
Even if it's just a tiny amount, like literally just a single drop of pink or brown discharge on the toilet paper.
Even then, any bleeding at all. Now, sometimes starting HRT can cause a little transient bleeding as the body adjusts to the new hormones, but it must always be checked out to be safe.
What are the typical causes?
There are many completely benign causes. It could be severe vaginal tearing from the GSM we talked about. It could be cervical polyps, or it could be something called an atrophic endometrium.
Wait, atrophic, what? Break that down for me.
Atrophic endometrium. So that endometrium is the lining of the uterus. Without estrogen, that lining can become so thin, dry, and fragile atrophic that the tiny blood vessels just break open and shed a little bit of blood. It's harmless, but it causes spotting.
But you still have to go to the doctor for that.
You do, because while those benign causes are very common, postmenopausal bleeding is the primary early warning sign of endometrial cancer, cancer of the uterine lining.
So just to summarize for the listener.
Yeah.
In perimenopause, erratic bleeding, heavy bleeding, skipping months, that is all considered a totally normal part of the chaos.
Right.
But in postmenopause, bleeding is never normal. It is the fire alarm going off.
It's the body communicating that something requires immediate evaluation. But the good news, according to the urological guidelines, is that because bleeding is such a clear, visible symptom, 85% of endometrial cancers are caught at a very low, highly treatable stage. You just can't ignore the alarm. Don't panic, but don't ignore it.
So let's recap this whole journey for you listening. Postmenopause isn't a temporary affliction or a quick phase you just sort of suffer through. It is the permanent biological state that begins exactly 12 months after a final period, and it lasts for the rest of a woman's life. While it thankfully brings the end of PMS and menstrual bleeding, it ushers in a decades-long phase where the sudden loss of estrogen acts like a missing structural guardian. This requires proactive management, not just for the persistent hot flashes, but for the silent risks to the heart, the bones, and the progressive physical changes of GSM. And treatments like HRT and local estrogen are incredibly effective tools designed to be used safely for the long haul.
This raises an important question, though. If postmenopause is a phase that makes up a third, or even a half, of a woman's entire lifespan, why do we culturally continue to treat it as an ending or a period of decline?
Right.
We frame it as a loss of youth rather than the acquisition of a massive, uninterrupted block of life.
So we leave you with this final thought to mull over today. Imagine how medical research, workplace policies, and our everyday societal attitudes might transform if we start viewing postmenopause as a medical deficiency. What if, instead, we started designing our world to optimize the health, the wisdom, and the power of women in what is literally the longest chapter of their lives? Because when the storm passes, you don't just survive in the rubble, you build a stronger house. Thank you for joining us on this deep dive.